Hi, good evening, everyone. This is Dr. Arbaz, and the topic of today's lecture for the class of 2023 is jaw relationship, recording maxillomandibular relationship, specifically orientation and vertical jaw relation. So, today we'll be covering orientation and vertical jaw relationship, which is a part of maxillomandibular relationship. So, on. The learning outcomes expected from you are you should be able to classify what a jaw relationship is based on GPT definition. You should be able to describe the various parts and the importance of the FACEBOW. You must be able to infer the methods involved in determining vertical relationship, as well as you should be able to point out the effects of increase and decrease vertical dimension of occlusion. So the steps, you should also be able to plan and outline the steps involved in recording vertical relationship, establishing a label form, and the occlusal plane. So let's move on. Maxillomandibular relationship or jaw relationship is defined as any spatial relationship of the maxilla to the mandible and any one of the infinite relationship of the mandible to the maxilla according to GPT. There are three types of maxillomandibular relationship. One is the orientation jaw relationship, second is a vertical jaw relationship, and finally we have the horizontal jaw relationship. Now orientation jaw relationships are those that orient the mandible to the cranium in such a way that when the mandible is kept in its most posterior position, the mandible can rotate in the sagittal plane around an imaginary transverse axis passing near or through the condyle, which is termed as a terminal hinge axis. It can be recorded with an instrument known as a phase bow. So a phase bow is a device that is used to record the relationship of the maxilla to the terminal hinge axis, and this in turn helps us to record the relationship of the mandible to the cranium, and this relationship is then transferred to a semi-adjustable articulator which simulates the patient's terminal hinge axis. Now, what is a terminal hinge axis? Terminal hinge axis is the axis along which the mandible rotates purely in a rotatory fashion without any protrusive or sliding movements. So as I said, terminal hinge axis is a purely rotatory movement, and this is orientation jaw relationship or FACEBOW is used to record the relationship of the mandible to the cranium. So ultimately we want to record the spatial relationship of mandible to the patient's cranium. So, as I said, FACEBOW is a caliper-like device that is used to record the relationship of the maxillary teeth to the position of the condyle when it is in the terminal hinge axis position, and this allows the information to be transferred to a semi-adjustable or a fully adjustable articulator when the casts are mounted after the jaw relationship. Now, what are the various parts of a FACEBOW? There are many different manufacturers that make different models of face bows, but essentially face bow parts consist of a U-shaped frame, a bite fork which is attached to the U-shaped frame with a lock nut. We have an orbital pointer which rests on the orbital on the inferior border of the orbit, and this acts as the anterior reference point. And we have earpiece or fascia type of pieces that act as a posterior reference point, and these are the locking devices that are used to lock the FACEBOW in position. Now coming to the types of the FACEBOW. Basically FACEBOWs are classified into two broad categories. One is the arbitrary type of FACEBOW and second is a kinematic type of FACEBOW. But here we'll be talking only about the arbitrary type of FACEBOW because this is the type of FACEBOW that is almost always used. The hinge axis is approximately located, that is why it is called as an arbitrary FACEBOW. Arbitrary phase bows are again divided into two types depending upon the posterior landmarks, that is the fascia type of phase bow and earpiece type of phase bow. In a fascia type of phase bow, the approximate posterior reference points are placed directly over the temporomandibular joint, that is on the skin over the TMJ about 1.3 centimeters anterior to the tragus of the ear, and that's why they are called as a fascia type of FACEBOW. In a earpiece type of FACEBOW, the posterior reference points go inside the external auditory meatus of the patient, and that's why they are called as earpiece type of FACEBOW. Now, coming to the vertical jaw relationship, the first step in the jaw relationship is the adjustment of the occlusal rim. The occlusal rim has to be adjusted in order to have good lip support and labial fullness, to have a proper overjet, so that the maxillary teeth can be set in an ideal relationship to the mandibular teeth. There should be sufficient incisal show during rest and when patient smiles. There should be sufficient cheek support and buccal fullness because of the wax rim. And the wax rim should also establish the level of the occlusal plane to which the teeth will be set, and the orientation of the occlusal plane in relation to the anatomical planes on the patient's face. Now, first, the upper, that is the maxillary wax rim, is adjusted for lip support and labial fullness. If the maxillary wax rim is too bulky or bulbous, it will result in a protruded lip, and if it is too retruding or too narrow, it will result in a insufficient lip support and labial fullness. So this is how a correct maxillary wax rim should look like, with proper lip support, labial fullness, and a proper occlusal plane, and as well as cheek support. Next is the level of the occlusal rim. The level of the maxillary occlusal rim should follow the anatomical planes like I mentioned, and it should show 2 mm of incisal visibility, so that when the teeth are set, they are visible up to 2 mm of the incisal edge of the teeth are showing anteriorly. In case of a lower occlusal rim, the occlusal plane should be parallel to the upper maxillary occlusal rim, and it should posteriorly be at the level of the 2/3 of the retromolar pad, and anteriorly it should be up to the level of the commissures of the mouth and the vermilion border of the lip. So, as I mentioned, the maxillary occlusal rim follows anatomical planes such as it should be parallel to the alatragal line laterally, and anteriorly it should be parallel to the interpupillary line. As can be seen in these pictures, anteriorly it is parallel to the interpupillary line, and posteriorly it is parallel to the alatragal line, and this parallelism is checked with an instrument called as a Fox plane. So, coming to the FACEBOW transfer, so I'll let this video do the talking, because somehow when I try to sync my audio with the videos, it is not getting synced properly. So let us take a look at first at the orientation jaw relationship, that is the FACEBOW transfer. So these are the parts of the FACEBOW. So, coming to the vertical jaw relationship, in vertical jaw relationship, the length of the face as determined by the amount of the separation of the jaw is called vertical jaw relationship. It is a vertical distance between two selected points, one on the maxilla and the second on the mandible. So in vertical jaw relationship, essentially, we are only recording the vertical space between the two ridges, that is maxilla and the mandible. 2 points, reference points, are marked on the patient's face. Patient is seated in an upright position so that his facial musculature, that is muscles of elevation and depressor muscles, are in a state of tonic equilibrium. And recording of the jaw relationship, that is vertical jaw relationship, involves two steps, that is recording the vertical dimension of occlusion and recording the vertical dimension of rest. Vertical dimension of occlusion is the distance measured between 2 points when the occluding members, that is the upper and lower wax rims, are in intimate contact. And vertical dimension of rest is the distance between two selected points, that is, as I mentioned, one on the maxilla, one on the mandible. And this is when the jaws are in a state of physiologic rest position, that is, the jaw upper and lower wax rims are apart from each other. So now, physiologic rest position is the position the mandible assumes when the head is in an upright position and the involved muscles of mastication are in a tonic equilibrium, that is, they are neutral and unrestrained. This position assumed by the mandible when the attached muscles are in a state of tonic equilibrium is noted, as I mentioned, only when the head is held upright. Now, next, coming to the vertical dimension of rest. So, physiological rest position and vertical dimension of rest are interrelated. So, vertical dimension of rest is equal to the vertical dimension of occlusion plus the freeway space. That is, the space between the upper and lower back streams is called as a freeway space, and this freeway space occurs when the jaws are in a physiological rest position. Okay, so this is referred to as a vertical dimension of rest, and when the occluding surface of the maxillary mandibular rim are in contact with each other, it is referred to as vertical dimension of occlusion. These can be recorded by facial measurements, by tactile sensation, by measurement of anatomical landmarks, by speech, and by facial expression. So coming to the measuring the vertical dimension at rest. First, the maxillary rim is inserted and the patient is asked to say M repeatedly. This relaxes the facial muscles and the lips are parted to check the space. While parting the lips, patient must not move the jaws or the lips. Then we measure the jaw separation at rest of the mandible, and this is repeated 4 to 5 times to verify that the readings are accurate. Now, as I mentioned, in vertical jaw relationship, if this VDR at rest, patient is upright, and 2 points are taken reference point. That is, one is in the maxilla, another is in the mandible, and patient is told to say M repeatedly. So when the lips come in contact, the measurements are taken with a scale, ruler, or a vernier caliper. So this is essentially what happens in the vertical dimension of rest, and this is a video that shows this procedure, which is fairly simple. So next, coming to the vertical dimension of occlusion. So as I mentioned, vertical dimension of occlusion is measured when the occludal rims or the teeth are in contact with each other. There are different methods. The mechanical method is we can measure the distance from the incisive papilla to the mandibular incisors by verifying the parallelism of the ridges. We can also use pre-extraction records of the patient, like profile photographs of the patient when they were young with their teeth, to get an idea of how, whether they had a long face or a round face or a square face, by from the profile silhouette of the patients when they had their teeth. These are all roughly auxiliary measures used to verify the vertical dimension of occlusion. There is no one single method that is superior over the other. Other things like patient's old denture can be used and measured with a Bowley gauge to attain the vertical dimension of occlusion when the dentures are in contact with each other. So the third most popular method are the physiological methods, and the most popular one in this is the Niswanger's method. Other methods like phonetics, aesthetics, swallowing threshold, tactile sensation, just like in vertical dimension of rest, are also used. So the relationship is should be parallel to each other when the patient is at physiological rest position. The distance of the incisor papilla from the incisal edges of the mandibular teeth is approximately 4 mm in the natural dentition and about 6 mm in case of a central incisors. Parallelism of the ridges, maxillomandibular ridges have a +5 degree opening in the posterior region, and this gives us a clue about the jaw separation in the patient. As I said, measurement of the formal dentures using a Bowley gauge, the denture height can be measured to get an appropriate idea about the vertical dimension of occlusion beforehand, before that is it is verified or measured in the patient's mouth. And as I mentioned, Niswanger's method, which comes under the physiological method, is the most common method used for uh, measuring the vertical dimension of occlusion. Again, two markings, one on the maxilla and one in the mandible, are made, and the patient is told to swallow, and distance between the marks is measured. The occlusal adjusted so that there is a 2 to 4 mm opening between the occlusion during the occlusion and during the rest. The disadvantages are the marks on the skin can move. So this is again a video that
Hence, the
shows
physiologic
the So next physiological method is phonetics. Listening to speech and sound production and observing the teeth in relation to the speech gives us an idea about the vertical jaw relationship and the position of the lip fullness and the position of the wax rim. Production of sounds like sh, s, and j sounds brings the anterior teeth close to each other. That is, the incisal edges of the maxillary anterior teeth are just above the incisal edges of the mandibular anterior teeth. So this is how it should be in the wax rim also. Also, when pronouncing these words, there is a clearance of 1 to 2 mm between the incisal edges of the upper and lower teeth when patient says church or s. This is referred to as a silverman's closest speaking space. If the distance, that is the vertical dimension of occlusion and vertical dimension of rest, is too large, the anterior teeth will touch when these sounds are made. That is, vertical dimension of occlusion is very small, and if the teeth click together during the speech also, it is known that the vertical dimension of occlusion is more. So next method, logical method, is a swallowing threshold. That is Patient swallowing threshold is used for determining the vertical dimension of occlusion. So, a vertical dimension of rest. So, maxillary occlusal rim is placed in the patient's mouth. On the mandibular occlusal rim, uh, something like 3 mounds of mouth temperature wax are made, and the patient is repeatedly told to swallow, and until these mounds are reduced to an even height. And this gives us a fair idea of the vertical dimension in the patient. Next is the tactile sense and patient comfort. Just like tactile sense for the vertical dimension of rest, using central bearing plates like the one shown in the picture over here. One plate is attached to the maxillary occlusal rim, another plate is attached to the mandibular occlusal rim, and there is a screw attached to the central bearing plate. And when the screw is turned, the separation between the upper and lower rims increases, and this screw is turned, or the vertical separation is opened up until the patient feels comfortable. And using a jig, these central bearing plates along with the wax rims are mounted on the articulator. So this is a central bearing plate as attached to maxillary and mandibular rim. So another instrument that can be used in physiological method is the GNATHO dynamometer. As the name suggests, dynamometer is any device that is used to record the force. So in this case, the forces of the jaws is used to record the vertical dimension. And usually a metal plate is attached to the maxillary record base. This is a spring dynamometer that is attached to the mandibular record base. One is attached to the maxillary record base and one is attached to the mandibular record base. And then the patient is asked to bite on these prongs or tongs that are extending from the GNATHO dynamometer, and the pressure is noted, and the highest value, that is how much the patient can bite to what extent, is referred to as a power point or the maximum occlusal strength, and this gives us the idea of the vertical dimension of occlusion. So coming to the sequelae of the improper vertical dimension, that is what happens when the VDO and VDR are too more or too less. So vertical dimension of occlusion, as I mentioned, there should be separation of 2 mm between the VDO and VDR, but sometimes if the vertical dimension is increased, it can result in many things, such as patient may experience discomfort, and the patient may also have pain in the jaws, in the residual ridges or the load bearing areas of the jaw. If the vertical dimension of occlusion is decreased, then there will be inefficiency, that is patient cannot chew properly the food, and it becomes difficult for him to eat. If the vertical dimension of occlusion is increased, there, as I mentioned, there will be trauma to the denture bearing area. And if the vertical dimension is decreased, we will have cheek bites. Also, when the vertical dimension is increased, also cheek bites can occur. Both the increase and decrease in the vertical dimension can result in temporomandibular joint problems, facial distortion due to either stretching of the cheeks or the insufficient support of the cheeks and the lips. So these things should be corrected beforehand during the procedure, or they will need to be corrected after the denture insertion during the denture review appointment. So Brings us to the same thing was shown in the video, that is the effect of the increased or decreased vertical dimension of occlusion. As I said, if the increased vertical dimension is there will be discomfort, there will trauma to the mucous membrane, the freeway space is obliterated, obviously the muscles are always fatigued, and when the patient talks there is always clicking of the teeth because there is no freeway space. The face appears long, the muscles of the cheek and face appear stretched, and a continuous excessive pressure on the residual ulnar regions will cause resorption, not to mention the pain in the TMJ. And decreased vertical dimension, as I mentioned, will cause cheek biting, the lack of tonicity of the cheek and the lips, and because of the lack of decreased vertical dimension, there will be angular cheilitis because of a drooping of the angle of the mouth, and again there will be pain in the temporomandibular joint. So brings us to the end of this lecture, and these are the list of books for reference purposes. So please go through them.